Good afternoon. I would like to introduce Dr. Niranjan Kavdi. Dr. Niranjan Kavdi was born and grew up in Pune. He graduated his MBBS from BJ Medical College, Pune. He completed his MS Orthopaedics in KEM Hospital and GSMC Medical College in Mumbai in 2008. Then he served as an assistant professor in the Orthopaedic Surgery at BJ Medical College. I would like to introduce Dr. Niranjan Kavdi. Dr. Niranjan Kavdi was born in 2010 to pursue his subspecialty fellowship training, and he did super specialties in pediatric orthopedics at Massachusetts General Surgery Harvard Medical College program and spine surgery in University of Alabama and State University of New York upstate. He has been practicing as a full-time orthopedic spine surgeon in Oklahoma City and Oklahoma, USA since 2014. Currently, he is a clinical associate professor and site director in the orthopedic surgery residency program at the University of Oklahoma Health Sciences Center in the Oklahoma City. I hand over to Dr. Niranjan, sir, to continue with his talk.
Thank you. Thank you, Orthopedic Department, MIMER. Thank you for having me. I'm excited to be here, and congratulations to all the graduating residents. It's a big feat when you graduate from orthopedic surgery residency program. And somebody told me, my mentors back then, when you graduate, that's actually when you start your journey. So that's when you start for exploring for your field. And there are actually three things that you have to decide. So mainly what type of practice you want to be in. You want to be in a freelance private practice, or you want to be in an academic institution, you want to be with the hospital. So that's one aspect of it. Then second thing, you have to decide the place where you want to go. You want to be in a metro, or you want to be in a smaller city. And then third thing, of course, is the specialty which you want to do. You want to do general orthopedics, or nowadays there seems to be trend in training further in subspecialties and then practice only subspecialty or some mixture of general orthopedics and subspecialty. So like I said, I grew up in Pune, and I did my residency at KEM. At that time, didn't have much thought of coming to the US. I was actually going to practice in Pune, but after that, talking to few friends, there were a few friends and few colleagues, few seniors from KEM, and some of them from BJ as well, who came to the US. And after talking to them, and then after coming to the US for first time, after doing all the exams, then just evaluating all the options. Especially, I didn't have anybody from my family who is a physician, so there was nobody guiding as such. You have to explore the field yourself. So without further delay, I'm just going to get started with US. How I came to the US is I took my USMLE exams while I was in KEM, while I was completing my residency. And then after that, I was in BJ as assistant professor in orthopedics. So I took part of the USMLE exams then. Then after that, I came here. So the opportunities for training in the US, of course, at some point, people decide if you want to be in the US for short term or you want to be here for long term. Your training opportunities after residency is fellowship opportunities. Of course, there are observership opportunities as well. Depends how long of a course you want. Right immediately out of your residency, I would recommend a fellowship, which is usually 6 months to 1 year. If you have been in practice, of course, just seeing for a few weeks, just learning a new technique, that's a different thing. But fellowships, usually, so for applying for all fellowships, you need a USMLE, the United States Medical Licensing Examination. So USMLE has 3 parts, essentially. The part 1, which is part 1 and part 2, these are theory exams. These are written exams. So part 1 includes all of your subjects for MBBS year 1 and year 2. all the basic sciences, anatomy, physiology, biochemistry, pathology, microbiology, all of the basic sciences. And part 2, CK, which is the clinical knowledge, that includes all of the clinical subjects, the medicine, surgery, obstetrics, gynecology, and the allied subspecialties. The third part of it, so the second part is divided into two, the part 2 CK, or the clinical knowledge, and part 2 CS, or the clinical skills. The difference between that is the clinical knowledge is more of a theory exam. The clinical skills is more of patient interaction. So that is just for us, and we are essentially the foreign graduates. So for us to get used to the American ways, the US ways of interacting with the patient, of clinic encounters. So that is the clinical skills part, and essentially they'll be testing your patient interaction skills, the counseling skills. One part of that is also your English communication. After you graduate from the CS, then you take the step 3 of the USMLE, which is again more of clinical part, but it's clinical and patient scenarios. They will give you the actual patient scenarios, and then you have to solve those patient scenarios. It's an exhaustive exam, usually like 2 days in a row, 8 hours. So it's an exhaustive exam. That's something that you can take right before your fellowship. So after you have graduated from your CS, then you can start applying for fellowships. So how to apply for fellowships, that's the most important thing, the resources, because when I was doing my MS, I didn't have the slightest idea how to apply for any of the fellowships or how to go for further training. So USMLE is, you're just doing the exams, but that does not automatically get you qualified for the entrance into the fellowships. You have to actually apply for the fellowships. So the way to apply for fellowships, earlier it used to be you would apply individually for all the fellowships, but now you'll have to go through the process called SF Match. So it's a San Francisco match. It's a matching board, and they will have all the applications, and you will be competing from people all over the globe. Mostly, of course, 90% of them are American graduates from orthopedic residencies, but people will come from all over the globe. And you applied it through the SF Match, and then the timeline, usually, remember, if you want to get into the program in 2023, then you start applying now. You start preparing now. So typically the match happens 2 years before you start the program. So 2021, 2020, now the match that will start now will be for 2022. So you have to keep that timeline in mind. Now, the SF match process, once you go through the SF match process and the program accepts you, then you got to decide whether you want to go for that program or you want to apply for post-match. Now, there are fine rules about that, what you can accept, what you can refuse, and then all of that you can find on the sfmatch.org, that website. So that will be your resource for all the fellowship match. Then on individual society websites, so when you decide your subspecialty, sometimes I have seen people coming here and doing different subspecialties. Again, it depends on what type of visa you have. But you can choose, suppose you choose joint reconstruction, then you can go on the AAHKS website, the American Academy of Hip and Knee Surgeons website, and they will, under the education section, you can find the information about all the fellowship programs. You can find the same thing about sports medicine. If you go to aofas.org, you can find about foot and ankle fellowships. On North American Spine Society, you can find about the spine fellowships. It's spine.org. So essentially all of these subspecialty societies under education tab, you can find all the fellowship programs. Now, getting into the fellowship programs, if you clear USMLE, of course, you have to have good scores, but that does not necessarily mean that you will be eligible. You'll be eligible to get into the program. Okay, well, I see questions popping up on the side. As soon as I'm done with this, I'll start answering all of these questions. All of these websites I'll put in the chat as well. So that does not automatically qualify you to get into the fellowship. So there's a ACGME, which does the accreditation for the fellowship programs. The requirements to get into the fellowship programs, these are constantly changing. The entry point was a little bit more flexible, a little bit more open for foreign graduates. When I came here about 11 years ago, now some of the policies have changed. For example, for sports medicine, they have made it a little tough. So there's a body called American Board of Orthopaedic Surgery, which is like our MS degree. After we are done with the residency, you will take an exam, which is usually a two-part exam, the theory and the oral exam, and then you become ABOS, or American Board of Orthopaedic Surgery board certified, which is essentially the MS degree holding like on our side. But some of these programs will require you to be ABOS board certified, or at least eligible, meaning you should have passed the part 1 or at least the theory exam, which coming from our residency, that's impossible. To write the American Board of Orthopaedic Surgery exam, it's impossible because they don't accept our residency to sit for that exam. Some of the programs, so for example, foot and ankle, for example, hand, they have kept it flexible. Pediatric orthopedics, they have said that if you're board certified in your country, meaning if you have a degree which is MS or DMB and 3 years of residency, then they will look at your application. Sports medicine, to some extent, joint reconstruction, they're saying if you need to get into the program, you need to have American board certification. And some of the programs, for example, spine or oncology, they're a little flexible. They have said we will first prefer the American board certified graduates, but if not available, or if the foreign graduate is exceptional, then we will consider them for the fellowships. So that is your pathway to get into the fellowships. I'll put all the website names in the chat as well. Now, after your fellowship, of course, with the fellowships, the third thing, one thing is doing the USMLEs, second thing is qualifying through this SF match, and the third thing, of course, is more related to the immigration part, the visa part. So that we'll leave that part out. It's not related to the medical field, but that's one consideration additional that you have to give, especially these days with changing policies. So once you get into the fellowship program, the way you decide is some fellowship programs have got more of research, some will have more of clinical, and depending upon how much of operative experience individual fellowship offers and what your long-term goals are, if you want to stay within the US or you want to get a subspecialty training and then go back to India and practice in some city in India, what you want will entirely depend on that. And once you graduate, then you decide your further course of action, what you want to do. Now, who said in the past that American Board of Orthopaedic Surgery certification, if you graduate from the fellowship and you have been practicing in the US for some time, then they have, of course, several criteria for that, but then you can apply for American Board of Orthopaedic Surgery board certification. And that's absolutely critical to keep practicing within the US. That's considered like equivalent like our MS degree. So you won't be able to practice longer term without that. So this is essentially the brief view, and I'll open it to questions. I want to actually get more questions, and I'm pretty sure many people will have questions. Okay, so okay, the websites, yes, I will put them in the chat box. till what extent is the role of research and publication to get eligible for the USMLE program? So USMLE is just an exam. There is no eligibility for that. The eligibility for that is your MBBS. And people who are focused, I have seen, they will take their USMLE exams during their MBBS days. So while you are in third year, you can take your step 1 USMLE, and right out of third year, when you're in your internship, you can take your type 2 or 2CK of the USMLE. So there is no eligibility or any qualification required for just taking the USMLEs. You can take the USMLE anytime. The research and publication, that's something they will look at when they pick you for the fellowships. So, of course, if you have research, good quality research, you will have higher preference. That's something that's valued, and that's something they will give preference for. Also, some people, what they will do is they will come to the US first for research fellowship. Even before taking their USMLEs, they will come to US just for the research fellowship purposes. You can get these fellowships for 3 months, 6 months. Again, the information for these fellowships you will find on individual subspecialty websites, their society websites. I'll put those in chat. And there you'll get the information for research. Research is just dedicated to clinical research or basic science research. You can choose any one of those, but I know of several people who have done those fellowships for 3 months, 6 months, or even a year, because that increases your chances of getting into the clinical program. But yes, that's for entering the fellowship program. That's not necessarily just for taking the USMLEs. Do fellowship applications also take into consideration our research publications, community service, and leadership positions? Absolutely. Yes, all of these will be considered. So, of course, the highest value is going to be your research and your publications and your USMLE scores. Those two will be your highest ranks. But yes, if you have served, say in Africa, if you have done mission trips, that will be counted. Yes, if you have leadership positions with the high-level organizations in the orthopedic field, yes, that will be counted. If you're on the editorial board of Indian Journal of Orthopedics, yes, that will be counted. All of these will be plus points in your favor.
Thank you, Dr. Niranjan, sir, for this wonderful talk. If anyone is having any questions, you can please ask.
Hi, hello. It's nice to
just
see
want to ask.
your faces. Hello, Zamkar, sir. Hello, Swapnil.
Niranjan, after a long time.
Yes,
very nice talk. Hi, very good. I'm very much. Yeah. He's a mentor for me. Niranjan is my mentor throughout my MBBS and MS, and I know what he speaks is really golden words. So just all the residents just listen, and what he advises is true and opt. How are you, Niranjan?
Good. Thank you so much, Swapnil. Thank you for kind words. Good to see you. It's good to see all the colleagues, friends.
Yeah.
I saw several familiar names, familiar faces. Good to see Zamkar sir after a long time. Good to see Swapnil.
Yeah. All be judged.
Yeah.
Niranjan, where are you now?
I'm in Oklahoma, US.
Very good.
I'm now the site director and associate professor with the University of Oklahoma.
Very good. I'm very proud of you.
Thank you, sir.
I routinely go to US. Maybe I'll, if you can just send me particulars on my jamkar@gmail.com.
Yes, sir. I will do that. Yes, sir. Yeah. I think I remember I talked to you a long time ago, sir, when you came here to meet Paket.
Yeah. I'm just Maya was talking. Sorry, Niranjan.
Yeah, good to see madam.
We used to fight for the spine cases in BJ. Jamka ma'am must have a regarding cases in the OT. Yeah, that's all nostalgic.
It is. No, but I still.
You to take care, Niranjan?
I'm sorry.
Sir, I'll interrupt this conversation, sir. I think it's time for the next speaker to join. We'll take up the questions during the session, sir.
No problem.
Thank you. Thank you, Dr. Niranjan, for this wonderful talk. It's indeed a good inspiration for us, and regarding how to apply for fellowships in the US and how to get into the fellowships, and also guiding us for the visa requirements. Coming to the next talk, it is by Dr. Umesh Nagre. Dr. Umesh Nagre graduated his MBBS from BJ Medical College and Sassoon Hospital in Pune in 1988. He completed his orthopedic post-graduation training from the same institution in 2002. Subsequently, Dr. Nagre, he went to the UK for further training in September 2002. Initially, he worked in Queen's Medical Center, Nottingham, in sports medicine for 1 year and obtained his MS Sports Medicine degree from University of Nottingham, UK. He then received Queen's Award for and later joined in Southwest Thames as Orthopaedic Specialist Registrar Training Program at St. Thomas Hospital and Guy's Hospital in London. Dr. Nagre completed his MRCS in General Surgery from Royal College of Surgeons, England, at London and UK. He then completed FRCS Orthopaedics. Currently, he is working as an examiner for MRCS and FRCS exams in orthopedics. Dr. Nagre has conducted many training programs in joint replacement surgery and delivered numerous lectures all over the world. He has delivered lectures on computer navigation, that is GPS, total knee replacement, severe varus and valgus deformities of the knee all over the world. Dr. Nagre currently performs joint replacement surgeries at Dinanath Mangeshkar Hospital and Vishwara's Hospital in Pune. Thank you. Handing over to Dr. Nagre to continue.
Good afternoon, everyone. I will start sharing my screen first. Before I start, I would like to thank you, Orthopedic Department of MIMER Medical College, for giving me opportunity to share about my experiences and about the MRCS exam and talk about the orthopedic training in UK. Am I audible to everyone? Hello?
Yes, sir. You're audible.
Okay. So there is a vast difference between the US and UK training, as you may have seen that Niranjan has mentioned. And here in UK, there are lots of pathways are there to enter into the training programs. And we will discuss about that in second lecture. But the first step, because lots of candidates or lots of delegates were attending this session, they are doing MS Orthopedic or they are in they have completed MS Orthopedic and they want to go for abroad for further training. So the first step is cracking MRCS. I will not say cracking MRCS, but I will say that how to pass MRCS. So as an examiner, we have seen candidates preparing for MRCS and how they are making the mistakes and why they are failing during the MRCS examination. So let's start. So MRCS exam is divided into two parts, part 1 and part 2. You can say part A exam. So this is an intercollegiate exam. It's a 5-hour MCQ exam consisting of 2 papers. So the morning paper is 3 hours and afternoon paper is 2 hours duration. And this paper covers generic surgical sciences, applied knowledge, including core knowledge required in all 9 surgical specialties. So paper 1 is applied basic sciences and paper 2 is principle of surgery in general. So I would rather say that this part 1 exam is like your third year surgery exam. So all the questions are related to thinking that you are finishing your medical career and you are entering into the core surgical training. So as a pattern, core surgical training, they go through the different surgical specialties, including emergency medicine. So to achieve a pass in part A, candidate will be required to demonstrate a minimum level of competence in each paper and achieving, exceeding the pass mark set for the combined total mark of Part A. So candidate may attempt to pass the Part A of MRCS exam 6 times. So 6 times they can give the exam. But don't think about that. You can pass this exam in first attempt very well with your preparation. So syllabus is given on the website, but I will just go through this. This is basic sciences, then there is common surgical condition, surgical skills, then management of surgical patients, perioperative care, surgical care of pediatric patients, management of dying patient, organ and transplantation, and the behavior and leadership skill. So I have divided this part A into certain steps. So you should understand what MRCS Part A exam, what is MRCS Part A exam you just seen, and which college you have to choose. Then decide about the date of the exam, when you want to give the exam, and start your preparation. Then choose your study resources. Join the various Facebook and Telegram communities where the students and senior they are helping each other. So on Telegram website, I have added lots of books also. So you don't need to buy the books. There are lots of books are in PDF. Then revise what you read and hold on your nerves in the examination hall on the exam day, and don't do the silly mistakes. So understanding which college you want to choose. Right now, MRCS is an intercollegiate exam. When we are given the exam, there were different colleges, like Royal College of England was conducting separately, then Edinburgh was conducting separately. There are 4 Royal Colleges out there. England, Edinburgh, Glasgow, and Ireland. So now it's a common exam. It's a same exam. It's an intercollegiate exam, and it's crucial milestone for surgical career in UK. Because it determines whether the surgical trainee possesses the correct knowledge, skills, and attributes to complete the basic training and to progress to the higher level of specialist surgical training. So this is a very basic exam where you can diagnose the patient, you able to manage the patient very well, and you can transfer the patient to the correct surgical specialty safely. So all the websites are there: Edinburgh, England, Glasgow, and Ireland, and you can go through the websites also. I've given the links. So you need to decide what date you want basically for the exam. Why it is important? Because this exam held 3 times in January, April, and September, with booking closely approximately 2 months before the exam date. And as I mentioned, you need to decide the date and book the exam date. Why? Because if you don't book the date, your brain will be always in denial about the exam preparation. So if you're really serious, then book the date. Then choose your resources. What books you need to read, because this is a different exam. Then work on your weak areas, strengthen your basics, because this exam is mainly focused on the basics, and mix it with the right proportion of MCQ and EMQ, and you have to practice them every day till your exam. So do as many MCQ and EMQ throughout the preparation. So here I mentioned the best books for MRCS exam. The first book is a Basic Sciences for MRCS by Andrew Raftery. This book is a Bible, okay? So if you read this book by heart, this will help you throughout your career, even after when you start practicing any field, whether it's a cardiothoracic or neurosurgery or orthopedic, because MRCS is a basic step where you can go further for the higher surgical training, like you can choose any field, like neurosurgery, urology, but you have to have an MRCS exam or MRCS degree. Then you can, these are the mandatory books, what I am mentioning here, like MRCS Part A, which is by Catherine Parchment-Smith, and MRCS Part A, Part 2, like book 2, is the revision notes. And you should have this Oxford Handbook of Clinical Surgery, because it's really helpful in all the fields, because it's a concise book and it's best to read. And keep solving the MCQ and EMQ and going through that. There are lots of online sources are there, like a past test, online exams, and EMRCS is there. So you can get the membership of that also. And also definitely join Facebook and Telegram program. As I mentioned that I am on the Telegram group, and we continuously monitoring what students are putting there, and if there is something wrong, then we step in and we give the correct guidance. So these groups help you to understand your competition. That's very important. That how throughout the globe, how the candidates are preparing, and it's keep you motivated and help you for guidance for the study resources. And definitely you have to revise what you have read. Because 1 month before the exam, stop reading anything new. It's not good. So stick to the MCQ and EMQ for your revision, and you have to finish at least one revision before your final date. And here on the final date of the exam, part A, so stay composed, read questions carefully, and mark the questions as you attempt the questions, because you have a very less time, less than a minute to attempt each question. So I always tell people that you start reading word to word because your answer is there. So when you start reading the questions, and most of the questions they are repeated, most of the questions are from the clinical aspects. They are not like tell me this syndrome or tell me this characteristics or something odd which they ask in our exams. This is very simple questions, but they're tricky. Avoid silly mistakes. Then keep your sense of working, because you have to finish the exam and you have to finish all the questions, because you're attempting 180 questions in less than 2 hours. So don't get nervous, and if you study well, you will definitely clear this exam. So fine, you have done the part A and you're going for part B exam, which is the OSCE exam. It's a very structured exam where, because we don't have a habit of OSCE right now, but I have seen this year all DNB and surgical exams like a university exam, they're moving towards the OSCE style. So in this OSCE is the objective structured clinical examination, and this OSCE consists of 18 examination stations, each of 9 minutes duration, and there are 6 stations are there other than this 18. 2 are preparation stations, and remaining 4 are the rest station in between. And there are 2 circuits are there, because this exam run in 2 circuits. So there is a morning circuit and afternoon circuit, and the groups are then switched over. So every session there are like 24 candidates, and 12 divided into, and they do the exam. So these stations will examine you applied knowledge and applied skills. So in applied knowledge, consisting anatomy, surgical pathology, applied surgical sciences, and critical care. And when you see the applied skills, it consists of communication skills in giving and receiving information, history taking, and clinical and procedural skills. As Niranjan has mentioned, even in US also there is a big like an importance for the communication skills. The way you talk to the patient, your sympathy factor, empathy, we are seeing this throughout the exam, whether you are approaching for the applied knowledge or whether you are approaching for applied skills. So part B exam is objective structured, and as I mentioned, it tests your knowledge and the skills. Applied knowledge, there are 8 stations of 160 marks. Each station is 20 marks, and there are lots of questions are there. So you need to make sure that in those 9 minutes, you have to read the scenario very well, because as I mentioned, your answer is there. Though it's a critical care, because I examine for physiology and critical care, though I am a orthopedic surgeon, and I have to ask those questions to each and everyone, and I have to take you through that. So if you make a mistake, we always tell you that you go back and read the scenario again. So we guide you. So apply those, like you should identify those hints. And when you go for the applied skills, there are 10 stations are there, and there are 200 marks. So procedure skills and communication skills. Communication skills, there are 4 stations are there, like a giving history, making bad news, receiving information, or any history taking. Here, there are 2 examiners are there, and we are marking you all the time on your communication skills, your empathy, sympathy, the way you talk to the patients, and they carry a lot of mark in these stations, including the procedure skills also, how you explain to the patient, then how you do the procedure, the way you discard the sharps and everything. So there are small things are there, but those are very important. So during the exam, what we're checking, the General Medical Council, like USMAD exam is there. So the like way UK has a PLAB exam. So we are checking the GMC domain throughout the exam, your clinical knowledge and how you are applying those clinical knowledge to your patient's diagnosis. Then we are checking your clinical and technical skills. When you converse it with the patient, when you explain the procedure to the patient, or when you do the procedure itself. So we are checking that communication and of course your professionalism with the patient throughout the, this part 2 exam. And for part 2, these are the good book books to read. Like these are the books to read, like a doctor exam part B, like a revision guide, book 1 and book 2. So book 1 is a basic knowledge, and book 2 is about the communication skills. For anatomy, you should read this book, like a Get Through Anatomy, Essential Radiological Anatomy. And for surgical critical care, these are the 2 books you have to read. That's it. Like Mazhar Kanani for critical care, and there's one more book by him also. Then physiology, just same book, Applied Surgical Physiology by same Mazhar Kanani. And pathology, the only book you have to read is David Lowe, a surgical pathology book. So you in part 2 is just practice, practice, and practice. Like you at every opportunity, seeing a patient, presenting to your senior colleagues, and do your viva practice. So you stand, just grab hold of your seniors or your close colleague or your friend and start presenting. When you start talking, that time you will realize what mistakes you are making. That whether you are doing the history in 6 minutes, clinical examination in 6 minutes, because there are certain stations we have, it's mentioned that, okay, 6 minutes for the history taking or 6 minutes for the clinical examination. So don't waste your time in talking to the patient, because it's straight to the clinical examination. Introduce yourself, talk to the patient, identify yourself, check identity of patient, and then you start doing the examination directly. Don't waste your time on history. So we have seen that so many times. And deliberate practice is very important. Listen what you're saying and think over it. Because in communication, when you're talking to the patient, you should not use a lot of medical jargon like anemia and your hypertension, or common words are fine, but you should not say hernia, because lots of people will not understand that common hernia word. It's not that common. So you say that is there a swelling in your groin. So that's very important. And you should have the study groups. Part A or Part B, formulate a group, and you study, because you identify your weaknesses before the exam. Your colleague will tell you. It's the best way to practice. It's the best way to get feedback or give feedback and learn from the others. And you have to revise, and prepare for the specific scenarios. So this Part 2 exam is not like our own clinical practice, what you're practicing in India. There's a vast differences there. So I definitely advise you that you should go for some MRCS YYC course, Part B, and get orientation of exam. That's very, very important, because we have done this course. I have done the St. Guys and Thomas's course, and it helps you a lot. It gives you total insight of the exam. Right now, like-minded examiners, 10 or 15 examiners, we came together and we have started this MRCS Viva preparation course, which is exactly 2 days course, and we grind the candidates through this. Ideal time is 1 month before the exam. So you will understand that what are your weaknesses, and you can work on that, and you will not have any fear when you appear for the exam. So in summary, don't underestimate the communication skill element for this examination. It's one of the most important things they are checking, even if you think that your communication skills are good. So make sure that you know the game, you read, go through the websites, read what is the portion, and do the deliberate practice at every opportunity. And remember that your communication skills are continuously tested, and use it at your advantage. And that helps you a lot in passing your Part B. Thank you. So I will take the questions now. Hello? Hello? Hello?
Thank you, Dr. Umesh Nagre, for giving us Umesh Nagre, sir, for giving us nice guidance in how to crack MRCS. If anyone from the audience has any questions, you can please ask or type them in the chat. There is one question from the chat. After MS in India, can one match into ST3 training in UK, especially since
that's
one
my
is
next
exempted?
Yeah, that's my next talk, which is coming up now.
Okay, sir.
So MRCS is a gateway for any candidate who are appearing for the finishing MS and going in UK immediately. That's very, very important. because you will exempt the PLAB. Once you pass the MRCS, you don't need to do the PLAB. We have given the PLAB first and then MRCS and everything. But if you pass the MRCS, you are directly entering and matching for the jobs or residency programs. European Union candidates, they are out now. They're competing. Initially, they have just walk in and just getting the jobs. But because of the Brexit, there are lots of jobs are available right now in UK. Lots of training opportunity. I can tell you one thing. Because I'm on the interview panel also for the international candidates. So last year, out of 400 for junior level job, we appointed almost 320 candidates from India. You can imagine, almost 80%. And for the senior level or ST3 level job, there were applications of almost 350 jobs were there. And almost half, 165 or something taken up by the Indian candidates. Whether it's urology, surgery, orthopedic surgery, or neurosurgery, anything.
Thank you so much, sir.
Thank you, Dr. Umesh Nagre, sir. Coming on to the next talk. The next talk is by Dr. Saran, sir. Dr. Saran completed his PG from Bangalore and Pune. Then he was a past faculty also in MIMER Medical College. He has been in UK for around 6 years and worked in different places of England, from Bristol to Wales. Presently, Dr. Sarang is working as a senior fellow in South Manchester Stock Board. He has been a fellow in European Board of Trauma in Orthopaedics. Also has been a fellow in Royal College of Surgeons, Edinburgh. Dr. Sarang sir is presently also a representative of Surgical Specialty Board of Royal College, Edinburgh. Handing over the next talk to Dr. Sarang sir.
Hello, good afternoon, everybody. Can everyone hear me? And is my screen visible? Hello? Hello? Am I audible? Hello?
Yes, Arun, we can hear you.
Right. Good afternoon, everybody. It's
we can't. Do you have any slides? We can't see your slides.
You
need to share the screen.
Can I share my screen now?
If you click on share the screen, then you load your presentation there. Like you can see your, we can't see your screen yet.
Anyways, I don't think a screen would make a massive difference as such. I'll try doing that as we talk. It won't take much of the time as such. So I'm Sarang. I have been an ex-faculty at MIMER, and it's such a great thing coming back and talking to you all. So the first and foremost thing I feel, my topic itself is slightly kind of a bias. I'm being told to talk on challenges in UK practice. So I might, you might feel me a bit biased talking about only the drawbacks of coming to UK, but don't take it that way. I think you got to, Dr. Nagre has told in a great deal of how much opportunities UK can provide. But at the same time, you should know what are the slight kind of roadblocks which you'll hit and something that you'll have to negotiate as you come to UK. So first and foremost thing, I think it's quite important to know how UK and India training is different. In India, you do about 4 years or 5 years of undergraduation, and then You go on to do MS after 1 year of internship. As against this, in UK, you do about 5 years, 5.5 years of undergraduation, and then you get on to something called foundation training. Now, internship, that's equivalent to internship in India. And foundation training here is 2 years, which is quite extensive. In first year, pretty much F1, as it is called, first year foundation people, they are based in wards. But from F2, they pretty much take on any referrals, whichever specialty they are in, right from the beginning. And that's quite a challenging kind of environment they are put into quite early on. Now, this is not the case as in India. Hello? Hello, am I still on?
Yes, sir. Sarang, you are audible.
So this is not the case in India. So this is one of the basic differences I feel, which counts a lot as you go on to work in UK. Our experience slightly falls short immediately after MBBS. Now, I know you all have passed MS, and that might be a different story. But at the same time, when you start any job in UK, you're expected to know the basic stuff. And that's quite considered a very essential aspect. And a simple example is if you start on a junior rota or a junior or a middle grade rota, if there is a patient who's desaturated on the ward, if there is a patient who's unresponsive, you're in the front line, and you got to organize your resources and work accordingly. Now, there are pathways, no doubt about it, but it sometimes feels quite challenging because we are not exposed to that kind of environment back home. So this is one of the things I feel is a challenge. We all have gone through it, and we have negotiated it. It's not undoable, but it is sometimes a bit stressful to begin with. Second thing I feel is what is NHS in itself? NHS itself is a massive institute. The good part about NHS is it's extremely standardized, meaning if you work in one part of UK, then you are pretty much considered a person who knows about the system and who can work in any other part of the UK, be it a big hospital like a tertiary care hospital or a DGH, which is usually a smaller kind of hospital. So getting first job is sometimes a bit difficult. There are plenty of jobs, as Dr. Nagre has said, but first job is slightly a hurdle, simply because the references we give or the experience we show, GMC, which is a regulating body in UK, can't verify them directly. So that can be seen as a roadblock. Once you get your first job, whichever specialty it is, now obviously you'll be looking into orthopedics, but whichever specialty it is, that then opens a wide gate where you can then negotiate yourself into different jobs. But getting a job is a mandatory requirement to begin with. Now, one of the big, roadblocks or hurdles which most of the people after coming here have faced is progression. How do you progress in UK healthcare system? Now, NHS, as I've said, is a huge institute, and they have always required international graduates to fill in service posts. And by service post, we mean they're given a job, they have to do the job, and that's it. They're paid for it. Now, having said that, we always want to progress. We always want to get on to some sort of subspecialty. We always want to practice individually as a consultant in a subspecialty. And that can become a problem if you're in a service-oriented job. There are two ways of progression in this country. One is getting a training job, which is ST3, as most of you know, and there is a non-training job. Training job is about 6 years, from ST3 to ST8, as they call it, and it involves rotating into different specialties. Now, I think Dr. Nagre is going to talk about it a bit later. That is a sure short way of progression where you are assured of a job afterwards, and then you are assured of doing fellowships and stuff like that. But getting into training is a bit difficult, and as someone rightly pointed out, having experience, too much of experience back home can work against you. In fact, during COVID times this year, ST3 interviews, face-to-face interviews were absolutely cancelled. And because of that, all they looked into was a CV. And what all have you done over past few years. Now, what GMC looks into if they want to train people is they want people who have obviously gone through their foundation training and core training, and they shouldn't have more than 18 months of orthopedic experience. As soon as you have more than 18 months of orthopedic experience, they consider it slightly negatively and they start deducting points. That's where most of my friends here who have been trying to get into training lost this year, which is kind of a shame because unfortunately, more experience is not looked favorably in here, but that's how it is. Now, having said that, if you can't get into training, then non-training is not somewhere where you cannot progress, but it is something which you have to make a special effort on your side to ensure that you make progress in the right direction. We also call it self-directed learning, which means you have to make sure that you attend courses, you get everything signed off from your consultants. That sometimes is a bit of challenge because they are not obliged to do it as they would do with any training post. But it's always helpful to have a helpful department and you can get through it. Most of the people here, I'd say 70 to 80% of the people who come here do get into non-training jobs and then negotiate their way upwards by collecting data by themselves or collecting evidence by themselves. Again, one point to remember is UK is a system where they strongly believe in documenting everything you do. If you've done anything different, then they want you to document it, get it validated by someone, and that becomes an evidence. If you don't make it into evidence, you pretty much haven't done anything because you can't prove after 2 or 3 years that you have done something, be it a different surgery, a difficult surgery, or anything you have managed a patient on yourself differently. Make sure that you make assessment out of it and get it signed. That's how non-training jobs can help, but at the same time, you need to make sure that you keep collecting evidence. One of the other biggest roadblocks is passing FRCS. Now, obviously, when you're in training, you do FRCS at ST6 level here, which is about 3 to 4 years after you have been into the training post. FRCS is quite a rigorous exam, and it goes on for 2 days. First day is obviously all clinicals, where you see patients. There are long cases, short cases, and the second day is, now I'm talking about part B, obviously the clinical ones. Part A is the MCQ based. And part B, where it goes on for 2 days, as I've said. It's quite a rigorous exam in a sense that they are trying to pitch you up at the level where you will be seeing individual patients on your own within NHS constraints. So when you see patients, it's not like in India where you see a patient for 45 minutes, then the examiner comes in and then you talk about your case. Here, right from the word go, the examiner is watching you. So you'll have 6 cases like you would have in a clinic. The patients would be there. You just talk to them and make a plan and then move on to the second patient. And the examiners will just be watching you. They might ask you a question or two in between, but they try to replicate your usual day-to-day way of working into the exams, and that sometimes becomes quite stressful. Unfortunately, FRCS passing rate in non-training jobs are quite low, about 20 to 30%, I would say. And in training jobs, it's slightly high. And that simply boils down to more training opportunities that the trainees get than the non-training jobs, which are service-oriented jobs. Now, having passed FRCS, unfortunately, the journey doesn't end, because then you have to work for equivalent certificate. It's called CSER here. And equivalent certificate is basically saying that I'm equivalent to UK postgraduate in orthopedics, and that involves loads of paperwork. In fact, the application can go on to about 1,000 pages. Now, it's not difficult to get 1,000 pages if you have done all your assessments and stuff from the beginning, but that needs a plan. And that sometimes can take a lot of time and efforts. GMC is the regulating body here, and GMC is responsible for giving you primary registration to begin with, and the specialist registration afterwards as well. And there are certain set patterns here in which GMC keeps a tab on you, and they keep an eye on what you're doing. One of the things is having an appraisal every year. It's on the same lines as we have adopted in India, where after every 5 years we get our renewal of registration. Here it's called revalidation after 5 years. But for revalidation, you have to do appraisal. Every working doctor here needs to do an appraisal every year. And that's quite a serious business, where you sit with an appraiser who's nominated by GMC. He could be your colleague, he could be someone from a different department, he could be a consultant. You sit with him, and then you discuss what all have you done over a year. Show your CPD, as they call it, continuous professional development. Show what all you have learned and try and put into it. Then he looks into it, and then he passes it on to GMC, and then GMC would say, fine, he's okay for this year, but he needs to do so and so things in next 3 or 4 years. For revalidation, you have to have certain things done in those 5 years to make sure that you can continue practice. This is one thing which is, I don't know if it's different, but it's quite seriously taken up here, and one has to engage in it to really carry on working. And this can take, again, a lot of time and effort. After passing FRCS, what next? Subspecialty. The UK practice has evolved now, and pretty much you are expected to do a specialty. And it happens that you practice your subspecialty in your consultant post. So you'll do all sorts of trauma, obviously, which comes your way. Specialist trauma, say pelvis acetabular or spine, will obviously go to the specialist. But the other regular trauma is done by you. And then you have your individual elective, not elective, but subspecialty practice, be it spine, be it hip, knees, on your non-trauma days. So that's how the UK practice has evolved, and pretty much then you hone down your expertise into one specific area, and you then tend to only practice that. So fellowship is also a big thing here. Obviously, there are loads of fellowships in UK.
I think we have lost contact with Dr. Saran sir. Connecting.
Hello. Am I back? Hello.
Yes, Dr. Saran, we can see and we can hear you now.
I'm really sorry, Darpan.
No, it's okay. Yeah, I can understand.
So fellowship is a big thing, and getting a fellowship straight away from India, as I've said, it's not impossible, but it might be slightly difficult, again, for the same reasons that they don't know you much, and fellowship still involves working individually and doing emergency surgeries and stuff like that. So if they have no way to check your competencies and stuff, then they will be a bit hesitant. Now, Indian Orthopaedic Association has got a few tie-ups with some universities here, especially one in Glasgow. It's in the Golden Jubilee Hospital, where they do have a transfer or exchange program. And there are about 4 or 5 candidates from India who come every year to Glasgow Fellowship, which is quite a good fellowship. And I think this is something which be worth looking into. They are given provisional registration for a year to work. And I think this is one thing which you all could look at. But I would suggest going through a formal pathway would be ideal. Lastly, facing of challenges, obviously, consultant jobs as such in UK are not massive. It's like a pyramid. At the top, where consultants and the posts above lie, there are very less jobs, and at the bottom, where junior and middle grade jobs are, there are plenty. So you will have to be really good at, especially climbing the ladder. And sometimes people do get stuck at times in progression. I'm not saying it's impossible, but you need to take loads of efforts and know the system well. Unfortunately, the way it works here is, even if you are exceptionally good, I don't think you can cut on to the progression times. A year here and there, but most of the people would take what it takes to progress to the consultant job. It's a great place to be in. The working pattern is quite good. You get plenty of time for yourself. Social life, family life is always good. You'll always find Indian societies here. I had a few slides showing how we get involved here with Indian festivals and stuff as well. So it's not bad on those terms. You don't slog too much. You have got plenty of time for yourself and your hobbies. But at the same time, you can get lost into the system quite easily, which would mean that you lose out on showing your experience, and that might count against you. I think it's always, when you talk on such topics, it boils down to your personal experience, and my personal experience might not hold what can you say relevant to you. So I would strongly suggest it's always a personal perspective of how you look at things. And make sure you do justice to yourself. Make sure you do justice to your family and everyone around. Obviously, we are quite ambitious when we just pass out from, say, MBBS or MS, and we just want to conquer the world. But sometimes you have to limit your expectations. So what I feel is, there is no right or wrong, and there is no best or worst option. Whatever you choose, just make sure that you have got all information about it and stick to it. You'll always find your way. Thank you so much. Hello? Hello?
We can hear you, Saran. Where are you working now?
I'm in Stockport, South Manchester.
Okay, good. So you're done with the exams?
Yeah. Done with the
exams.
Yeah. Yes. All sorted.
Okay.
Yeah, we'll chat when free, whenever you have. Yeah. Any questions I can answer on the chat?
Good afternoon, Jamkar sir. Would you like to give your input, sir?
I think this is a nice presentation. I'm extremely proud. Almost all of them are my students, and they are marching on the Ashwamedh's horse in England. So at the end, they are doing this country as well as BJ Medical College very proud. So I'm proud of them. Especially everybody is doing great work there. I had an opportunity to spend 1 year in UK, where I did my fellowship in transplant surgery in Freeman Hospital in Newcastle upon Tyne. That was in 1996. And nowadays, it was very easy for us to go to UK. because all our degrees were recognized. In fact, had an appointment from that overseas clearing house as an SHO in 1975. But those days it was what is called a bus system. And once you miss the bus, I thought let us do MS here and then go. And then say went up. Anyway, I think this is very nice opportunity for all of us, especially our students. I hope all of you are members of BAPIO. Are you, Niranjan? Unmute yourself.
No, sir.
Yeah. There is something called as a British Association of Physicians of Indian origin. And I happen to collaborate with them. In fact, through BAPIO, all postgraduates who completed their degree can directly get appointment in NHS hospital for as a registrar. So anybody who is interested, they can contact me. I can send you there. In fact, now BAPIO in collaboration with Symbiosis, we are starting a MRCP program where 2 years they would spend in India and 2 years they would spend in UK. So that's also another opportunity. But for through BAPIO, you could get all residents who have completed MS can get registrar's post. Maybe they may not get the choice, but then we'll definitely try. Dr. Ramesh Mehta, who is the president of BAPIO, is working on this. And because I had several occasions to collaborate with BAPIO, in fact, through MUHS, we had a program to train, say, Government of Maharashtra Medical College lecturers for 2 years in UK. And then provided they come back and they serve the country for another 5 years. But that program didn't, say, take flight because of some government MOUs and all that. But anyway, I think at present there is a lot of opportunity. So anybody who is interested, if they contact me, I could help them to get some post in UK. I think let us congratulate Darpan and the Department of Orthopaedics for organizing such a nice program. So thank you, Darpan.
Thank you, Zamkar sir, and thank you, Sarang sir, for his wonderful guidance and challenges in orthopedic practice in UK. The next talk is Dr. by Umesh Nagre sir. Again, I would like to hand over the application for the topics of training in UK and practice in other European countries. Thank you.
Okay. I will start sharing my slides now. Can I start? Hello?
Yes, sir. Yes, sir, you're audible.
Yeah, good afternoon, and thank you again, MIMER Medical College Orthopedic Department. So Sarang has given the insight about the orthopedic training, and I just want to emphasize on the ways you can enter into the training, because there are certain loopholes are also there in the system. I will not say loopholes, it's mainly the you should know these places where you can stand, where you apply. You should apply to the correct post. That is very, very important, because I have seen people getting lost into the system and they just don't know what to do, and they're changing the profile, changing the career plans. Lots of my friends have become GP, or certain friends have changed the career, become radiologist and something like that. So obviously I will talk on the orthopedic training in UK now. So because this is an insight every candidate in orthopedics in India should know. So definitely our world is orthopedic is one of the most competitive surgical specialty for training, like radiology and anesthesia all over the world. And you need to prepare for this tough competition. As Sarang has mentioned, that there is a competition everywhere. and it's every step you're competing with so many graduates, local graduates and foreign graduates. But it's not certainly within reach. It's certainly within the reach. So the steps to work in UK determine your long-term goal, as everybody has mentioned. Even the first speaker also mentioned, Kawadi. Then get registered with the JMC, find a suitable job according to your experience and what you want. Then obviously obtain a visa and start working in NHS. So determine your long-term goal. What do you want to get out of like coming to UK? That is very, very important. So there are three choices are there. I have divided into three. Like become a recognized UK consultant in orthopedics and practice there. If that's your long-term goal, there is a separate path. Then work long-term as an orthopedic surgeon in UK without becoming a recognized consultant. That is a ACC grade or staff grade we say. Or then complete the UK orthopedic surgery fellowship, gain a UK experience and come back home. If you are clear about these ideas, then you find the correct jobs for you, for yourself, and then you progress further. So GMC registration is mandatory for every doctor so that you can practice safely in UK. So you have to create a GMC account. I will not go through the details, but IELTS is mandatory, your basic medical degree. And if you have any MRCS or FRCS certificate, then you can submit that. You have to have an internship completion certificate, and you should have a certificate of good standing from your local medical council. That's very, very important. Mainly they take it from the Indian Medical Association. So you need to provide a proof of clinical skills and knowledge. And so there are 4 options are available for orthopedic surgery. Either you can give PLAB. So people who are just graduated, they should give the PLAB and enter into the surgical training, like Saran also mentioned. I will go through that. Or if you are a postgraduate in any field, like whether it's orthopedic surgery, general surgery, or anything, you should pass your MRCS immediately. So ideal time for passing the MRCS or appearing for MRCS if you are doing the post-graduation in India is second year. Because second year is generally a very easy year and not that busy in your department. And this is the time you should sit down and crack the whole exam. We have a candidate from Dinanath Mangeshkar. His name is also Umesh. He passed his part A in second year start, like first 6 months. And next 6 months, yes, there is part 2. Then clear his DNB, clear his IELTS, and got the job within 6 months. He's already working in UK in Slough. Then FRCS is another way that if you have the FRCS orthopedic, you can directly go for the higher level job like a local consultant or staff grade. Or there are certain RCS sponsorship fellowships are there, where like a Royal College of Surgeons are sponsoring you for coming to UK and getting trained and sending you back after 2 years. So as Sarang had mentioned, you should find the suitable job. That is very, very important, which is a tough thing. Finding a suitable first job, because 2 main questions you have to consider when you're looking for the job. Like, do you have the right training and experience for the job? As Sarang has mentioned, once you finish the MS, you are overqualified because you have worked more than 18 months in your orthopedics. But I will say one more thing that I have been guided through this, that what you do, this is a hint. When you make your CV, when you show your 6 post, so you have to show your 1 post as an emergency medicine, because definitely you work in emergency medicine, handling the complex orthopedic trauma, initial phases, and then you can mention your subspecialty training in orthopedics when you make a CV, because there are point system is there in UK. When you submit your CV, there is a point system that you have an audit, you have a research, you have experience in neurosurgery, you have experience in plastic surgery, and you have experience in vascular surgery and emergency medicine. So during my career, I have done all these 4 jobs. And that helps you a lot because there is a point system is there, because neuro has 5 points, plastic has 5 points, and vascular has 3 points, and emergency medicine 2 points. Because if you have research and publications and audits, that helps you a lot. And try to work on your this audits presentation and your publications during your residency when you're in India, if you're doing the MS and thinking of going to UK, because if you have a publication in international journal, that counts a lot. And second question you have to ask is, will it lead to my long-term goal, like whether I want to become a consultant or I just want the experience, I want to go back, something like that. So that you should find the job that is not jeopardizing your long-term goal. So the certain tips are there. If you haven't completed your internship overseas, then only option to join is 2-year UK foundation program, as you mentioned, as a first job. Then you just get F1, F2, then you apply for the core surgical training like ST1, ST2, and ST3. It's a successive training, like you don't need to come out. But it's ST1 to ST8, and you choose your career. And after ST2, once you've done the MRCS, you have a choice to diversify your career, that I want to go for the trauma and orthopedics, or I want to go for general surgery, etc. like that, and you can choose about your career. And just make sure that you don't make yourself overqualified for your target specialty. That's very, very important. What happened? You finish your MS orthopedic here, and we are more comfortable in working in orthopedics only. So, as Sarang has mentioned, that there are certain situations, there are emergencies are there, and patient is desaturating, you are doing the APG, and as an orthopedic surgeon, including me also, when I seen the first APG, it was blank. Just certain numbers are there, and you are looking, you don't know what is metabolic acidosis, you don't know what is acidosis or alkalosis, or what patients is going through. Definitely there are help is there during the near or colleagues or anesthetics there, but you get fumble that time, and but we all get out of this. So there are certain things you need to make sure when you are doing the training in India. The ATLS course is mandatory. There are points are there. Then basic surgical skills is also mandatory during their training. So it is also need to be done. And you should do the AO fellowship, the basic training, AO fellowship training course. So that is very, very important, because that is one of the things they see when you apply for the ST3 job. So that's the thing, you should not make it overqualified. Then ideal first job include the, see, when you're going for the, after the doing MS orthopedic, then you should, though you get a non-training post, don't worry about that. You apply for the, because that's an entry point, and you have to get certain post during your, to enter into the UK or to enter into NHS. So non-training post should be the flexible one, where you are working as a non-training junior grade doctor for 6 months. You get the experience of the ward and what's happening in the system. You get acclimatized to the system, and then you progress towards your middle grade job. So there is an adjustment period is there, and all the trust right now when you employ the people, all the trust we are giving this chance to the candidate, that when we ask them, are you comfortable in working directly for the senior level? And if they say no, then we make sure that they will work at the junior level first. Obviously, visa and immigration, they are changing every day. But right now, tier 5 and tier 2 visas are there, and our friends will guide, but you go through the immigration website. So how to reach a long-term goal? The good thing about UK is there are pathways are very flexible, and there is a lot of options are there. So though your non-training jobs are there, as Sarang has mentioned, there was a working time directive, European working time directive, where you can work only for 48 hours. And this started, MMC has started certain, there is a ISCP is there, Intercollegiate Surgical Curriculum Program. They started these assessments like a CBD, then the PBA, like a procedure-based assessment. Though you are in non-training course, my advice is you register on the Edinburgh website or ISCP website and keep doing your DOPS. That doesn't matter. Catch hold of your consultant and surgical DOPS, present the cases, and get it assessed. That is very, very important. What happened in training course? When you are in training course, everything was mandatory, and it was mandatory for the trainer also, and it was mandatory for the trainee also, that we have to finish this. So make sure that during your training, don't get disheartened, and keep your goal focused and keep doing all these things. Make sure that in India, when you're doing the training, your logbook should be updated. And if you want to register, elogbook.com, which is a Royal College website, Edinburgh website, you can register there and keep adding your cases there, because it's very formalized, and you can just take a printout at the end of your 3 years and submit to MUHS, or you can use this for the GMC also, or your orthopedic jobs also. It's very concise. So your goal one is become a consultant. I want to become a consultant and stay in UK, or I want to get CCT, Certificate of Completion of Training. So if you want to be eligible for apply for the permanent post in NHS as a consultant, you need to be on the GMC specialist register. Like you get a general registration first when you apply for the first job, and when you finish your FRCS orthopedic and have a training, then you become a specialist register. So what are the entry possible routes are there? CCT is a through and through. You just get into the training and you come out of the training and you get CCT. Then CESR is there, and there is CESR CP is there. We will go through that. So CCT pathway for the international medical graduate, I'm only considering international medical graduates. It's the best for the new graduates, like a fresh students finishing their MBBS in India and going to UK. And they have finished the plan, they have to do the plan. Or they can finish the MRCS within a 1 year, and they should apply for this post because they are the most new candidate, and entering into the system is very easy for them. And if you have more than 18 experience in surgical specialty, after internship anywhere in the world, then you will be deemed overqualified for CT1 job, which is a ST1 job, and you cannot pursue the career for CCT route. So in these circumstances, you must go for the other routes. You will see that. So this is a typical CCT that you entered into the foundation program. This is a 2-year foundation program, or you should have the 1-year internship and 1-year UK foundation program, or 1-year post internship experience in acute surgical specialty. So the candidates who are looking for this program, I will advise them, once you finish your internship, go for the acute surgical specialty if you want to career in surgery. The most common job they will look into it is emergency medicine. You have to do this, and the second job are related. Whether it's orthopedic, then you should do neurosurgery. Whether you want to enter into the cardiothoracic, you should do vascular surgery. Then after that, or there is a 1-year UK VAST training is there. I will go through that also. So then you progress to the core training, which is a ST1 or CT1 they say. This is a 2-year UK core surgical training where you will rotate it through the different specialties like vascular 6 months, then or 4 months, then emergency medicine 4 months, like that. So they will cover all the surgical specialty. And eventually you will enter the higher surgical training, which is a ST3 level, and you will finish your 6 years trauma and orthopedic training. At the end of the 6th year, ST6, you will appear for FRCS, and that's by exam. And as Saran has mentioned, it's part A and part B, and it's a tough exam. I was I'm examiner for these exams also, and we see that it's a tough exam. And once you finish this exam, you get a CCT. Because last 2 years you do the fellowship. I want to become a shoulder. I want to do shoulder. I want to do complex trauma. I want to do pelvic trauma, or I want to do arthroplasty. Then you take your next 2 years accordingly, and you become a UK consultant. Even for this CCT, it's not necessary that after CCT that you will get the consultant post for sure in UK, because there is a pyramid and there is a bottleneck competition even for UK graduates also. But with CCT, your whole world is open to you. That you can go to Singapore, you can go to Australia, New Zealand, Canada, anywhere, because that training with the CCT certificate is recognized. So you can get the jobs other than UK anywhere, Ireland, and even in the Europe also, because the whole training is recognized. So that is the advantage of doing the CCT. And I've mentioned the VAST training. So what is the VAST? It is a 12-month long course which help to prepare and enable international graduates to apply for the first year specialty training. So it fulfills the requirement. It is suitable as a first job. Lots of jobs are available. You can enter into the ST1 or CT1 level job very easily, and you can pursue your career. So when you enter into the VAST also, I always mention, and even mentioned in the previous talk also, that you should identify the job other than orthopedics. If you want to do the orthopedics, try to collect the points for your orthopedic training, like do neurosurgery, it helps a lot. Do plastic, it helps a lot. Or do vascular, it helps a lot. The jobs are available, so you should focus on that and do those jobs. So once you've done that, you get the points also, and you get very shortlisted very easily for ST3 interviews. So second pathway is a CESR CP pathway in trauma and orthopedic. So what is this pathway? We are the graduates, international graduates. After finishing the MS, we are overqualified. Until you get the UK job, you're still working in India, and you have the experience more than 5 years. If you have the experience less than 5 years, then you can apply for this. The usual entry point into the surgical training is ST3 level, so you would end up completing 6 years of orthopedic training program. So you don't need to do the CT1, ST1, all these jobs. But this is the other way where you can start your jobs and you can still finish your residency program Sometimes there's the training post, sometimes there's the non-training post. Sometimes you can apply for the multiple locum post, like a locum specialist registrar, LAS, they call LAS post. LAS post is normally recognized for the training. So you can take this is a registrar level job, you can take this job in different places, but make sure that you will do all the subspecialty like shoulders, ankles, arthroplasty 6 months like that, or spine 6 months. So ideal first job is non-training, there's no problem, and you should see the progression and there's an adjustment also. Be sure that whatever job you choose, you will able to fulfill the eligibility requirement. As Sarang has mentioned, during your training, do your competency-based assessment regularly. And as you mentioned, there is an appraisal system is there, which is very good, and we should start in India also. There is a 360-degree appraisal is there, where you are assessed not by your consultant, including your ward nurses, including your ward boys or your juniors. Everybody assesses you. They're continuously assessing you. Are there any complaints against you, or any patients' appraisal letters are there? If there is patient appraisal letter, keep this as your profile in your CV or in your portfolio. So according to GMC rule, there's a good news is there that CESR, this new pathway, CESR CP route, who complete at least 5 years in UK training program with FRCS, they will be awarded CCT, like a certificate of completion of training, and you will enter into the specialist register. So that is a good thing about getting the CCT through this pathway. And if you complete less than 5 years, then you will just get a CESR. So better way to complete the 5 year and get the certificate. So this is a foundation training 12 months, then core surgical training, then higher surgical training, and you get the CCT basically. So here you entered in the higher surgical training at ST3 level, and you don't need to do all these things, because for satisfying this criteria, you need to have the validated logbook of your surgical procedure. So maintaining your logbook is very, very important. Then certificate of readiness to enter into the higher surgical training and your MRCS exam. So yeah, your references work here. So whichever consultant you are working in UK or in India, the references will work very well here. And if you have the MRCS at earliest, that works very well, and you enter into the surgical training program. The last one is CSR. There is Article 14 that you are really experienced. So this is a certificate of eligibility for specialist registration. So what happened? You are already experienced here. I'm done the MS. I'm practicing in India for 10-15 years, and now I want to go to UK. I want to change my whole career plan now, and I'm not worried about the residency. I just want to go and work there, and I'm not worried about the training program also. So there is another way. Is Article 14 is there, and as Saran has mentioned, that you have to. There is a system that I have put the this website addresses also. So this website address CSR at the bottom, it's on GMC website. It will guide you. It's almost 1,000 pages article. Like you have to submit all the degrees and your experiences, your logbook, your appraisals, your procedure-based assessments, everything. So you have to submit that, and at the end, if they satisfy, they will give you the specialist registration and you can practice. But you don't become consultant with Article 14. You work as a staff grade or associate specialist. So this is a training pattern. Like you don't need to do foundation. You have done the internship. You have done a lot of training in India and consultant post, and then you follow the CESR in trauma and orthopedic, and you become a associate grade or equivalent to a consultant. But just remember one thing: if you do this and if you still get the CESR certificate, there is a problem with this, that you will not able to get the consultant post without CCT certificate outside India, outside UK. They are very sure about that, because Australia, New Zealand, even Gulf, they look for this CCT certificate. That is very, very important. So your second goal is like you want to do orthopedic training but without becoming a recognized consultant. So potential job is clinical fellow or specialty doctor. So whatever job you start, you can always seek the promotion, stay with the same employer. Like in the same department, you can change the job. Like right now I work in the shoulder for 6 months. Then next 6 months I will work for spine. Next 6 months I will work for other posts like arthroplasty or spine, something like that, and go through the CSR route. So obviously the exams are there. You have to qualify the MRCS, as I mentioned previous talk, and you have to do the FRCS exam. Two parts: part one, part two. Part one is written test, and part two is extensive 2 days practical and oral exam. And everybody has to do both the parts by the end of their ST8 post. And most of the training take this exam within the ST6. So we have done this. I will not repeat this again. So FRCS trauma I have mentioned. So the last goal is that you want to do the fellowships only. Lots of candidates are there in India. They say that no, doctor, I just want to go to UK. I want to get experience in arthroscopy or orthoplasty or spine for 2 years, and I want to come back. Fine, there is no issue about that. The best way to enter and getting the GMC registration is passing the MRCS. Once you have the MRCS, all doors are open. All 3 goals you can achieve anytime. There is no problem. So if you want the experience, then you can join a program which is suitable for your ambitions. Then apply for the fellowship programs. Lots of fellowships are there. And don't get the observership, because lots of people go there and just do the observation and come back. So if you want to really work and get the hands-on, then get the registration and apply for the fellowships where you get the salary also and where you get the experience also. So these are the website if you want to have more information, detailed information. So this is for ST3 programs. This is the intercollegiate website for the MRCS, and this is there are certain articles are there. Then Joint Surgical Society is there, which will guide you what are the documentation you will require. So all the things are mentioned in this website. So you can have a look through this. Thank you. Hello. So if anybody have the questions, then we can go through the questions.
Good afternoon, sir.
Good afternoon.
Hello. Sir, I wanted to ask if we give MRCS Part A, when can we give MRCS Part B?
Immediately within 3 months. There is no issue, because see, your theoretical knowledge is ready. It's just your applying that knowledge. And because the cases are not difficult, I told you, it's a simple hip examination is there. And I'm not looking for the special science. I'm looking for how you talk to the patient. You have to see the gait, how the patient walks. These are like a tick boxes are there, because I'm marking the person on that. Then you have to do the Thomas test. You have to mention about the shortening, and you have to do the other test like a X-rays. And I will show you the X-ray, because we are looking for very basic things.
Thank you, sir.
So there is one question from the chat. We are told about spine surgeon. It is to study neurosurgery somewhere in the talk. Can you please elaborate on it again? So.
Yeah, like what I mentioned, that during your earlier gate, that if you want to go through that CCT route, then instead of doing only orthopedic jobs or applying for the orthopedic job, it is better to go for certain other job. You know, the VAST I mentioned, WAST, that associate training. So you go for neurosurgery training, which is a 6-month post, and it's really good, because I did neurosurgery in Oxford, and it's really wonderful, because they will drill you very well, and that time you will learn all the basic things about the neurosurgery, because there is a point system is there when your CV gets shortlisted for ST3 post, or you can do plastic surgery. It's a really good job. Anywhere you get the SHO post, or even clinical fellow post, to do that 6 months of plastic surgery helps a lot. Instead of doing orthopedics and getting that, okay, oh, you are overqualified now. Instead of that, it is better to do these 2 allied posts, which is very good. Now, obviously, the spine surgery is a specialized, then you can do it during your fellowship program. There's no issue about that. There are lots of standalone fellowships are there, if you guys know about this. Once you get the MRCS and somebody want to just go for the fellowships, then the spine fellowships are available, lots of spine fellowships. Even in Nottingham, where I got trained, there's a big department of spine. They have almost 8 to 10 spine fellows overseas.
Umesh sir, can you just display your last slide, sir, which has all the websites shown?
I think you have recorded, right? You can share the slide. I don't have any issues.
Okay, right, sir.
You have the slides, right? That okay. Wait a minute. I will show you. Just hold on. If somebody want to take a snapshot, then that also. This is the last slide.
Yes, thank you, sir.
If anybody want the information, you can see these slides. There is no issue.
Sir, thank you, sir. Would like to continue with the next talk, sir. Yes. About the opportunity.
So I'm going to discuss about the opportunity in Europe now. Sriram asked me about this. I was doing a little bit. I had to do a lot of study also because I trained in UK. So see, the main problem in doing fellowship in Europe is the language. Just remember this. If you want a hands-on fellowship, where you want to go to Europe and practice there, see day-to-day patients in clinic, and do the operative along with the consultant, then it's better to have the language skills. And if you know the French or if you know the German, so it's mandatory. And if you want to progress, because right now, UK is a problem because it's a pyramid. So the bottleneck is there. And very few consultant posts and lots of people are applying for that consultant jobs. But in Europe right now, there is lots of opportunities out there to become an orthopedic consultant and to settle down there or come back also. There's no problem. But there are certain things you need to make sure that decide about your goal before deciding or choosing the country. Like Europe has almost 37 or 38 countries, European Union, which are a part of this global program now. And then choose the country for training and look for the fellowship. And language is mandatory, it's compulsory. If you want to go to France for the, I'm not thinking about the observership, I'm not talking about the observership. People go to weekly, do the observership, work with the consultant, come back. I'm talking about the paid fellowship or paid jobs or paid regular orthopedic residency program, which will give you CCT of that own country. And you have choice of staying back or you can go further. And, once you can practice anywhere in Europe. So you have to go through the local orthopedic training website also. So there are certain things that you should know about this. UEMS, which is the European Union of Medical Specialists. I think this is formed when there was a European Union was formed. And I think 1970 or something like that, this medical specialties, this union has formed. And over the period, they have seen that there is a separate training for Germany, separate training for France. There was no assessment. There was no assessment, there was no same assessment for the Spain also. And there was a problem of migration of consultants between the countries, like a Spanish consultant cannot practice in other places like Swiss or something like that. So they form a European Board of Orthopedics and Traumatology, which is the assessment, analyzing, and the examination board. So they do the regular exam. It was founded in 1999. Okay. And they started working on that. So eventually, you can see that over the period of the 12 years, they have seen that they found the European education platform. In this education platform, which was launched by the E4, E4 is the European Federation for Orthopedic Trainees or Orthopedic Surgeons, Trauma and Orthopedics. So they formulated an orthopedic curriculum. And this orthopedic curriculum is all over Europe, they are following the same curriculum now. And there is a EBOT exam is there, European Board of Exam is there, is every year. So if you are doing the 5-year training program, you are year 1 resident, then you have to pass the every year assessment basically. And it's a good thing because it's a exam in English. And definitely after passing that exam, your trainer or your department will also come to know that at what level you are standing basically and how you are progressing your career. So how it works, there is an annual EBOT interim exam is there. So I'm talking that you have got your all language skills. That if I want to go to Germany, then I will do the German exam A1, A2, B1, B2 and C exam. And I'm professionally qualified by the German Council. like his professional in linguistic skills. Then this is a further progress now. This is applied to all countries wherever you apply, whether it's Swedish or whether it's Finnish or it's Denmark or France. So there is a So there is an annual EBOT interim exam is there. So the part 1 is the EBOT written exam. It is in English, and all the candidates appear for that. And part 2 is the national exam, which is a clinical exam. And sometimes it happens in the local language. So what happened? Initially it was in English, and hello, can you hear me? Hello.
Yes, sir, we can hear you.
Okay, sorry. So they have changed this pattern now. So right now, from they are doing the exam in local language also, French, German, and Spanish also. So local level they are doing the exam. And the part 3 is the EBOT oral exam is there. It happens in different languages wherever you are practicing in whichever country. And then you granted as a fellow of European Board of Orthopaedic and Traumatology at the end of the once you pass all the exam. And there is a local exam of their local orthopedic society also, you have to pass that. But once you get the fellow of European Board, then you can practice in any country in Europe. So these are the all website addresses are there. If you want to have the information, you can take a snapshot of this. And there is a orthopedic trainee website is there. This is a fordortho.org, and all the fellowships are mentioned. Then the ISCA fellowship is there. These are all the programs are mainly for the training and for doing the fellowship, which are paid for. So you are not going for the fellowship only, you are getting the payment also. And at the end of the training, you can think about coming back, or you can think about settling in that country, or you can think about planning in anywhere in Europe. Thank you. So it is better to go for the UK because English is our language and we speak English. But if somebody really want to go and explore something in Europe, this is the right way because there are lots of jobs and it's just working basically. You just apply for the post and you get the job training post. I will take the questions on that.
Any questions from the audience? You can give them in the chat. Thank you, Dr. Umesh Nagre, sir, for your wonderful talk on training in UK and practices in the European countries. I would now like to invite upon Dr. Shirish Narsapur. Dr. Shirish Narsapur completed his D Ortho from CPS Bombay and DNB Hosmat Bangalore. Further fellowship in arthroscopy in sports medicine under Dr. Dinshaw Kadiwala in Mumbai, Dr. Hennis Laprel in Germany, and fellowship in shoulder scopy under Dr. Michael Cantrell in USA. He is currently working in Oman since 2014. I would like Dr. Shirish to continue.
Hello all. Thank you, Dr. Otkar and Dr. Kamath, Dr. Dharpan, for giving me the opportunity to share with the budding orthopedic surgeons the experience of working in Gulf. I have a short presentation which I made a few slides. Nothing great, but let me initiate the presentation. I don't know if you can see the whole slide as once or at once, or you're seeing it slide by slide. I don't know, but on my screen it is shown as.
So we can see all together, sir.
All together. Okay, I don't know how to change it, but anyway, just to the thing. First of all, I'd like to congratulate all the trainees who have cleared their MS and D Ortho and now looking at new avenues. Abhi to party shuru hui hai. So. Since all of our eminent colleagues have talked about settling in UK or US and other affluent nations, affluent countries, of course, the process there is quite tedious and you need to have lots of certifications and some amount of experience. Also, as Dr. Nagre was mentioning that more than 18 months of experience is taken as a setback, especially if you're going to UK. The thing is different if you're looking at Gulf. Now, why one must be looking at Gulf? One thing is moolah, money. Of course, there is a lot of money. I mean, the money is a deciding factor for most people who come to Gulf. Comparatively, it's an easy way to practice. If you are looking at practicing outside India, as an orthopedic surgeon, your options are very limited. So comparatively, it's an easy getaway. There is not much of scrutiny, and most of the countries have their own small exams, like which can be taken online. Prometric exam is called. Theory exams, which are which range from 2 hours to 3 hours. It's a single paper. For Oman, it's 70 marks, and for UAE, it's 100 marks. So you need to get about 65 to 70%, depending on which exam you're taking, to clear the exam. Once you clear that exam, there's a nominal viva voce, on which general questions will be asked based on your experience, what is your work field, and then you get the license. It's very simple as compared to UK, US, or Australia, Singapore, elsewhere. Second thing, another thing, it's closer to home. They're just about 2.5 hours, 3 hours flight from India. So anybody looking at those people who feel that, no, I'm homesick, I cannot travel long distance, this is the best getaway for them. Also, there's a lot of time here. You can work, you can take out time for extracurricular activities, all those things. Now, why I chose to come to Gulf here was primarily for the monetary reason. I was working as a registrar in Columbia, Asia after I finished my fellowship in arthroscopy. I was working there as a registrar in Columbia Asia Hospital in Bangalore, and after that I changed to Fortis Hospital. After working there for about 2 years, I realized there is not much of a growth if I continue to work there as a registrar. Because the growth in private sector in India, or the private sector in India, depends upon how much cases you're getting to the hospital. That's the corporate rule. And for that, you need to be a consultant. And that early in the practice, nobody was ready to take me as a consultant, even though I had good enough experience of working in corporation hospitals in Bombay, and then working in MIMER hospital also for 6 months. I was there in the medical college. And after that, I worked in hospital. I have worked in few places, got good enough experience. But anyway, that's the other story. And I was even skeptical of opening a private practice. I was not very much keen on investing a lot of money in opening up private practice. So all those things were bothering me, and that's how I decided that okay, Gulf sounds like a good opportunity, because I have not taken USMLE on. I have not a good option, because there are lots of football players here, and there are lots of arthroscopy cases. So if you have a specialty in arthroscopy or some fellowship in arthroscopy, your chances of getting into Gulf are so much brighter. Trauma, of course, that is the bread and butter, but majority of the road traffic accidents, majority of these high velocity traumas, as a rule, they go to the government setup here. If you are working in a private, most of us will be applying for private institutes here itself. So generally we get these domestic traumas, like both bones or fracture tibia, fracture femur. So the common things which generally in our residency training we would have gone through. So, I mean, you should have a good knowledge of trauma. That's the thing. So arthroscopy is the main thing. If you have arthroscopy, you have a very bright chance of coming in here. Spine is the next. If you have interest in spine, if you had some fellowships in spine about 1 year or 2 years, also spine, there are plenty of cases here to operate in Gulf. Arthroplasty generally is reserved for consultants, even spine. If you have spine training for about a year or two, fine, you can come here and join as a spine surgeon. Arthroplasty is generally reserved for consultants, although I do operate joint surgeries here, but they're not that frequent, because arthroplasty as a rule has to be done by a consultant here. For consultants, you need minimum 8 years of experience. After that, you need to go through that the viva voce procedure also again. Now, when you talk about Gulf, there are lots of countries here. There's Saudi Arabia, Oman, Dubai, United Arab Emirates, Qatar, Kuwait. Now, which one do you want to choose? Why? I think staying here for the past 6 years, I've come to realize that I know about the majority of the countries, how the atmosphere is and what kind of work you get there, and what to expect, basically. the largest country in the Gulf, the Saudi Arabia, I would strictly not recommend, because they have entirely too many strict rules for you to enjoy the life, be free. Basically, the first thing they'll do is keep your passport. So that's not what you want when you're going outside the country. And that's not what you want. So I would not recommend Saudi Arabia. I would not say no, strict no, but personally speaking, I would not recommend Saudi Arabia. Next comes Qatar and Bahrain. Generally, the entry there is very easy. There is no examination. All you need to do is just show your experience paper and get your papers verified through the data flow. That's all is needed. There are no examinations. But the thing is, the salary to the cost of living ratio is not that good. I mean, they're expensive. Qatar is the most richest country in the world. But yes, of course, the cost of living is high, but the salaries are comparatively in the Gulf, they're not very high. So that's the thing which you want to think about. Advantage in Qatar is you don't need a visa. As an Indian passport holder, you don't need a visa. You can just directly go inside the country, have your experience. You can just go and talk. If they are happy with them, they'll process your papers, and then yes, your job is done. You can join there immediately. Kuwait also sounds like a good option when you take into account the salary to cost of living ratio. Kuwait is good enough. It's good to medium, in fact, I would say. But there are certain things. The borders are unstable. Kuwait borders Iraq, as you know, and that area is little unstable. So anything can happen anytime. So be cautious if you are applying to Kuwait. UAE, the best of the lot in lifestyle sense. In the sense of lifestyle, UAE is the best of the lot. That UAE includes Sharjah, Dubai, and Abu Dhabi. There are other Emirates also, but they're far off places. But you will be looking at only these three: the Sharjah, Dubai, and Abu Dhabi itself. The UAE by far is the most difficult to get into in terms of orthopedic practice, because the scrutiny level is a little high. The exams are a little tougher as compared to other Gulf states. And yes, you need to have at least 3 to 4 years of experience if you're looking at entering UAE. The ratio between what you earn and what you spend depends upon the lifestyle, what you want to enjoy. In UAE, you can earn and you can spend. You can earn, you can spend. And hardly any saving possible. But yes, you can enjoy a very good life there. But if you want to save, of course, you'll have to sacrifice on certain things, but you can save well also there. By far, not that I'm staying in Oman, but since I visited these countries here, I have come to realize that Oman is the best place to come in, because the salaries are good, decent to very good salaries, and savings is also very good, and you get to operate cases on your own. In UAE, most often you would be working under some American or European consultants. So it's basically you'll be like a registrar, or at the most you'll be working in a clinic where you'll be seeing only the OPDs and there will be hardly any surgical cases. That's one thing which you would, as a budding orthopedic surgeon or just come out of, when you have 1 or 2 years of experience, you would want to weigh whether your experience or whether you would like to lose your skill for want of money. That's one thing which I also thought that, coming to Gulf, maybe I'll not get so many cases to operate and I might lose my skills. But thankfully, nothing of that sort has happened because I have joined a hospital. Yes, in case if I had joined a medical center or a clinic, probably I would have lost all my surgical skills by this time. So that's one thing which you should be knowing. You should not be joining any clinics or medical centers. But if it's like you want to move out and there is no option, you're desperate to move out, clinics also sounds like a good option because they are attached to hospitals generally, wherein you might get a case or two a month to operate. But prefer to get an attachment to join a hospital as a full-timer. In Oman, of course, before coming to Oman, I had already had fellowship under Dr. Pardiwala and a month of observership in Germany. So I was aware of arthroscopy cases. I was doing arthroscopy cases myself in India. So that was an advantage for me in Oman. The moment I came here and I started off well. thing in Gulf is you get a lot of time. There are people who come to Gulf who would come with a set of mind that, okay, I get a lot of time, I'll study. And people from here, they've done MRCS, they have done FRCS, they've done MLEs, and then they have flown off to UK and US. So this can be utilized as a stopgap, which is possibly not the case when we are working back in India. There's a lot of workload. The commute takes a long time in India. From commuting from your house to the hospital, back in the traffic, it takes a long time, and you hardly get any time to study. So there are the options. I mean, when you come to Gulf, time for further studies you definitely get. Or if you want to come here, save the money and start up your own setup back up home, that's also possible. Yes, of course. You can come here, work for 2 years, 4 years, get a decent amount of saving, and then you can start up your own thing. If that's what you have in your mind, that's also done. Or the other option is make hay while the sun shines, work here as long as it's possible for you to work, make some good money, go back and retire. Of course, the grass looks greener on the other side. There are pros and cons. I would like to talk about the pros first. The moment you come here, yes, of course, the bank balance is immediately there. From the first month onwards, it's a good salary. Probably your contemporaries are not making much as compared in India. Then, as I mentioned, there'll be a lot of time for your extracurricular activities. You can enjoy your hobbies. You can explore your talents. There is a lot of family time around here. I stay 20 kilometers from my hospital, but it takes only 12 minutes for me to travel. So that's hardly anything. And I cannot imagine that situation back home in Bangalore, where I used to go work. Fortis Hospital was just about 8 kilometers from my place, but it used to take me half an hour, 40 minutes in the peak time to go, and another half an hour to come, 40 minutes to come back. So you can imagine, I just take 12 minutes here in 20 kilometers. So that's hardly anything. So I get a lot of family time. Basically, dimag ka dahi nahi hota yahan pe. So that's an advantage. There's a lot. Those are the pros. Cons. When you're looking at earning in Gulf, the salaries tend to be pretty much fixed. They hardly negotiate the salaries with what you have done, unless you have changed the job, of course. So you reach an immediate plateau. Monetarily, you reach an immediate plateau. For example, like if two orthopedic friends, A and B, they have started off. B has started his practice in ABC, considered 3 friends. B has started his practice in India. C has also started his practice in India, and A has come to Gulf. A would start earning decent 3.5 to 4 lakh salaries per month initially. B and C are struggling for the first 3 or 4 years, but A is making up that much money. C struggles. At the end of 10 years, C is still struggling, but B has picked up after about 5 years, and in the next 5 years, he has made up almost, you can say, 10 lakhs to 15 lakhs per month. But A who has been in Oman or in Gulf has been making that 3 or 4 lakh per month right from the first day of the 10 years. So it all depends upon the case, like what you want to see. Every time you cannot be comparing, but I just gave an example. Your practice may click, may not click when in India. If you're looking at primarily, say, having some good savings and everything, I think Gulf is a good choice. But other thing, plateau. It reaches the plateau immediately, and after that, there is hardly any growth in money. Cases, number of cases as compared to India are definitely less, but I'm happy with the number of cases which I'm doing here. I'm doing about 15 surgeries a month, out of which 7 to 8 are arthroscopies. So I'm able to continue with my skill. I have got enough time to even go and do a short-term fellowship in US also in shoulder surgery and everything. Academics is not much here. So if you're interested in academics, of course, medical colleges only you'll have to look at here. There's only one medical college, so there's not much academics here. But even then, I was able to give a paper on my work here in Astra Hospital on the arthroscopic ACL reconstruction. I presented a paper in Singapore Orthopaedic Conference last year. So it's not like a strict, but yes, academics is very less here. The other major thing is a prejudice, which back home a lot of people have against people who have worked in Gulf, which I faced. I mean, 2 years back, I wanted to go back to Bangalore, and immediately immediately I did not want to start up my own. So I applied for most of the corporate hospitals, and what I felt was they have a certain prejudice in their mind that, this person has worked in the Gulf, so he does not have any experience. That's not the case. Mostly that's not the case, because yes, we are getting number of cases here, we're operating, and so that's the thing which you have to live with. If you are in Gulf, for example, if a person who has worked in UK or US and has returned back to India, the value of that person, of that orthopedic surgeon, is way above. And their experience is counted as an experience, and they'll be considered as consultant. They'll be taken as consultants immediately, maybe, but you'll not be even considered to join anywhere. So that's a prejudice. Probably you'll have to live with it, but it's okay. Other thing, you don't want to become a lazy bone here. You got a lot of time. You explore, you do whatever you want, you study, you explore your talents, but you can also become a lazy bone, and you can be like a couch potato. Mera kaam ho gaya, main ghar jaake relax kar raha hu. So that's the thing which you need to keep in mind. All these things, decision making is yours. Calculate the options, what you have, what are your interests, whether they're academic, whether they're non-academic. Leaving India is definitely a big step. Well, if you want to go to UK, US, Australia, Singapore, you're looking at going there and settling. It's a long-term decision. But coming to Gulf, it's always temporary. The Gulf market is very volatile. You don't know what's going to happen in the next few months. The oil economy collapses, Gulf collapses, you'll have to go back. So these things which you have to keep in mind. But so far so good. It's been holding on for such a long time, and maybe for another at least a decade, the Gulf bubble is not going to burst. That's what the assessment is in general here. But whatever step you take, have no regrets and have full faith in yourself. And you have taken a decision, just back it up with as much of whatever efforts you can put in. And personally speaking, I have had no regrets. I've done well here. And if I move back to India now, probably I'll just open up a small clinic, and I'll be looking at retiring itself and not taking so much of headache. So I would thank you all for giving me the opportunity, and thank you all for listening to my talk.
Yeah, thank you so much, Dr. Shirish, for this wonderful talk. Let us see if there are any questions from any participants. We can wait for a minute or so.
Yeah, sure.
Yeah.
Hi. Hello.
Hello.
Darpan, hi. Shirish.
Hello, sir.
Hi.
Hello. Yeah.
I just want to add one thing. I work in Oman also. I have a clinic there. I used to work for clinic, and I used to operate in Aster. So that's just a visiting thing.
Yeah.
I used to go over the weekend and do that.
Okay.
I stopped that. See, as he mentioned clearly, that Shirish has taken the step. It's a big step. Whether you are going to UK, US, anywhere in the world, it's a big step. So think about it, first thing. And second thing is, any degree, UK degree basically, MRCS and FRCS, there is a red carpet, okay? There is a red carpet all over the world. I can add to that. Because I've been to the interview, I still remember, because I remember my days when I went to Oman for the interview. There was nothing. I just went, they seen my degrees, and that's it, consultant post. There was no interview, there was no exam, nothing. So this is a red carpet. So if somebody want to get that, and MRCS is possible in India basically. Second thing I forgotten to tell, don't do the international FRCS orthopedic, because it has no values. Lots of candidates don't know about this, and they keep spending a lot of money in appearing for this exam. Well, this exam happens in Qatar. And if you don't have the just a degree, for the degree you're doing, that's not a problem. Like coming back to India and practicing as a FRCS degree, there is no issue. But the international FRCS is not recognized if you want to apply for the Singapore consultant post or any other places. It's not recognized. That's the only thing I want to add. And thanks, Shirish, for reminding the olden days. It's a nice hospital. It's a nice hospital.
Yes, definitely.
I'm sorry. Thank you so much, Dr. Shirish, for such a wonderful talk. I think he has given a very good overview of all the different Gulf countries. It's impossible to talk about all the countries in one talk, but he has, I think, done justice to his talk. I also had a small stint in Gulf, and I agree to each point that he has said. That to summarize, I think Oman and UAE are one of the best options if someone is thinking of making out a career in Gulf. With that, we come to the end of this 4-day event called Horizons, the Path Ahead, which was initiated by the postgraduate students of our institute. In this session, we had 18 speakers from different super specialties and different areas of practice, ranging from joint replacement to arthroscopy to sports medicine, work culture in corporate hospitals. We also had speakers who spoke about the work experiences and pros and cons of government institutes. And of course, today's session, which was probably one of the most interesting sessions, where we talked about the various, three overseas options that postgraduate students are. I wholeheartedly thank all the speakers of today's session, Dr. Kavadi, Arun, Dr. Umesh Nagre sir, Dr. Saran, Dr. Shirish, Dr. Yagnik, who couldn't join us today for some reasons. I think this was a invaluable information that they have shared with us, which won't be possible for anyone to get browsing on internet or through the websites of respective field. I think it was quite composite, quite elaborate in a small session. And we are sure the orthopedic surgeons or the postgraduate students per se, they are one of the best brains in the entire society. So if they decide to pursue a particular career, nothing can stop them. Just they have to continue with their aims and with complete devotion, and they can achieve anything that they want. So just end note about before we come to the end of there is an observation that around 97% of orthopedic surgeons practice in the urban and semi-urban area, which caters around 27 to 28% of the population of the country. And there are just 3% orthopedic surgeons who practice in the rural area, which comprises of almost 72% of the population of the country. So I think this is a small point which each one of us should ponder upon before deciding their careers, about their social responsibilities. So with that, we come to the end of the session, this 4-day session. I wholeheartedly thank all the respected speakers. I thank each and every participant for being with us for all these 4 days. I thank my department, Dr. Prashant Kamath sir, Dr. Ashok Vatkar sir, Dr. Santosh Borkar sir, and my residents, Dr. Shrirang Godbole and Dr. Amay Nanandwar, who were instrumental in getting the things organized. With that, we come to the end of this session. Thank you. Thank you so much.
Thank you, Darpan.
Thank you, sir.
Thank you.
Thanks, Darpan. Thank you.